Welcome back to Balanced Health. Colorectal cancer is the third deadliest cancer in the U.S., but with proper screening, you can significantly reduce your risks. Today, we're discussing what screening and preventative steps each of us can take with our special guest, Dr. Dan O'Reilly. We were talking when we went to break about the new virtual scan or the CT scan in place of the colonoscopy, which is still the best test, right?
Yes, in my opinion, right.
Okay. And okay. So what's the downside of the CT?
Well, the problem with CT colonography is the false positive issue, where they find an abnormality and there's nothing there. But maybe the bigger objection is that if you find an abnormality, you then need to go through a second procedure. Colonoscopy allows you to diagnose and treat at the same time.
Oh, that's true. You snip the little polyp out, don't you?
Correct. So we're still kind of leaning toward colonoscopy. However, if a patient has a difficult colon to examine, if they're reluctant to do it because of the fear of complications, CT colonography is a good alternative, and it's a highly accurate procedure. Okay. It's not being done in all places yet. There's a little bit of issue with reimbursement from insurance companies, but I think it's going to catch on as an alternative to colonoscopy, as one of the other alternatives. And it will probably end up bringing more patients into the colonoscopy spectrum because we'll find more lesions. If people are reluctant to have a colonoscopy, but they'll go for CT colonography.
That's good. That's good.
Find
now,
a polyp and send them to us. You know.
Is it more expensive?
Probably, but I don't, medical economics being what it is, I call it voodoo economics. What we charge and what gets paid for medical procedures is all over the place. On paper, it's probably a little bit more, but if you factor in the cost of sedation and biopsies and things, it's apples and oranges. Okay. It's more expensive if you have to go through both procedures. But as a single screen, it may turn out to be less expensive.
Right. That's a good alternative. For those of you who have been scared to go in and do it, I mean, I definitely think you should consider that. I mean, you need to get screened. That's the important thing.
Let's talk about lifestyle for a minute. Obesity is getting blamed for an awful lot of things these days: heart disease, diabetes. We've had surgeons on here, who do joint surgery and whatnot, and they're saying that obesity is the single biggest factor in what they do because the overweight is bearing down on the joints and so on and so forth. What about colon cancer and colorectal cancer?
No, it's a risk factor. Obesity is an epidemic in our country, as you know. We've now created a new diagnosis called metabolic syndrome. It's the patient who's overweight, has diabetes, hyperlipidemia, fatty liver. These things all go hand in hand, and we just lump it together and call it the metabolic syndrome. Colon cancer appears to be one of those side effects of being overweight, and we're not quite sure why, whether it's due to glucose metabolism disorders or simply the presence of a higher fatty food content with carcinogens that may be present in the food products. But it clearly is one of the risk factors.
Yeah. Let's talk about that for a minute. I mean, what is a healthier way to eat for colon health?
Well, in general, for all health, but the colon probably specifically, high fiber, low fat. High fiber is the thing that keeps our bowels regular, keeps us moving. We talked earlier off camera about bowel cleansing. What's good to keep your bowels regular? Well, fiber keeps us regular, and it helps to eliminate whatever toxins and things we may be ingesting in our diet. So having a regular daily bowel movement is a good thing. That's why we eat the apple a day. It's why you eat your
well,
bread
I have to bring up my argument with Joe, and he says that you should have 2 or 3 bowel movements a day. And I say, well, I can see one, but if we had to eliminate that quickly, why have all this colon?
Good question. What's normal?
Yeah, what's normal?
We tell patients anywhere from 3 a day to 1 every 3 days, and that's a spectrum. 1 a day is the ideal. It's probably what we should, kind of strive for. But if someone goes 2 or 3 times a day and they're comfortable and they're healthy and they have no problems, we don't try to alter that. If they go every 2 to 3 days and they're comfortable and they're
so that's not unhealthy.
No, as long as you're regular and not bleeding and not straining with your bowel movements and getting plenty of fiber. If people get enough fiber, they're probably going to go more than every 3 days.
Yes.
You can overdo it with fiber, and we'll see patients will come in and say, "Gee, I go to the bathroom 5 times a day," and they'll be eating, a basket full of fiber in a day. Maybe that person needs to cut back a little bit. But in general, once a day is kind of the point that we shoot for.
I have another question, which I think is very important, and that's first of all, who's at higher risk, and what I'm really getting to, is this a genetic thing? Because I think that's a very important consideration. I know you mentioned that to Jerry, because when he got his cancer, you said if you have any siblings, have them go, be tested. Why did you say that?
Well, In general, our lifetime risk of getting colon cancer is about 5 to 6%. 1 in 20 people roughly will get colon cancer in their lifetime. Those risks are increased if you have a first-degree relative. If you have one sibling, parent, child, and occasionally we'll see a child who presents before the parents, it doubles your lifetime risk to probably about 10 to 12%. If you have multiple first-degree relatives, it goes up higher. And then there are genetic syndromes like familial polyposis and Lynch syndrome that also increase your risk. Inflammatory bowel disease is another risk factor for colon cancer. So clearly there are genetic issues and there are environmental issues, dietary issues primarily, but we talked about obesity, diabetes, other things that increase your risk. So lots of factors that play a part in the development of colon and rectal cancer.
You know, we talked about obesity. With childhood obesity on the rise, we've had several heart physicians on here, and they are expecting diabetes, adult onset diabetes, that term to go away because there's going to be so many teenagers with what we would prefer, recently calling adult onset diabetes. Is there going to be a prevalence, do you predict, or have you seen it already where the incidence of colon cancer is starting earlier because of childhood obesity?
No, I don't treat children, so I don't see that age group, but we don't see cancers in that age group. We'll see an occasional 25-year-old with colon cancer, a statistical oddity.
What is the average age?
Well, it goes up over age, and that's why our recommendation is by age 50 you get your baseline screening colonoscopy, because before age 50 it's pretty uncommon. Jury was an exception, and there are exceptions, and that's why you have to kind of fudge those rules a little bit. But if you've got a healthy adult who comes in and has no risk factors, they're not overweight, they have no family history, no symptoms, waiting till age 50 is a prudent recommendation for their first baseline screening intervention, whether it be CT colonography, colonoscopy, or any of the other screening tests that are available.
And I can't speak for all insurance agencies, but I think many insurance companies, I shouldn't say agency, many insurance companies will cover that baseline screening after 50, and then I think every 10 years, many insurances will pay for that.
In general, it's not true across the board. Medicare sets the tone, and they will now pay for screening colonoscopy once every 10 years. In general, private insurance tends to follow suit, and we're seeing more and more people come in their 50s, and it's being covered as a screening exam. So I think when Katie Couric put the big push on about 10 years ago, it really kind of opened people's eyes to colon cancer as a common problem in this country, and some of the rules and regulations have changed.
How about the male-female ratio?
It's a little bit more common in men than women, but it's still common in both.
It's fairly balanced?
It's still the third most common in both groups, although your 1 and 2 are different because of the breast cancer in women.
So your recommended protocol for the first screening is when? Did you say 40 or 50 years old?
Age 50, if you have no risk factors, symptoms, or family history. If you're just simply coming in and you're a healthy adult and you want to be screened, you should get your first colonoscopy by age 50.
For a general physical, do you recommend that people ask their physician to take a stool sample just in case of occult blood or something like that? Because just because you have blood in your stool doesn't mean you can always see it, right?
Correct, yes. I do. I think people should get regular checkups and should have fecal occult testing, which is the test that the doctor does when he takes a little smear of stool and puts it on a card and tests it for blood. It's not a perfect test, and that's when you talk about your false positives, false negatives, there's a lot of issues there. But
it's cause for further intervention, though.
It opens the conversation and gets a lot of people into the system.
Well, I think the message is we do need to be aware of it and get screened. We want to really thank you, Dr. O'Reilly, for being with us, and we look forward to doing another show with you very soon. Next week, Dr. O'Reilly will be joining us again, and we'll be discussing what screening tests you should get and how often you should get them. And we'll also look at treatment options for colorectal cancer, so be sure that you tune in. And after the break, Joe shows us what to look for when buying soap. Stay tuned. We'll be right back.